Good morning, chairpersons and the audience. As rightly said, this is a very common fracture. In spite of this being described about 200 years ago, we still don't know the correct way of treating it. As you all know, distal radial fracture is one of the most common fractures you see in orthopedic practice. Probably the K-wiring is one of the most common procedures done in orthopedics. And Abraham Collis has described this more than 200 years ago, and still we are not at the consensus of what the best treatment for it. But what he said was, if you put a plaster on, it will be fine, you get a good movement. But later on we have found that restoring anatomy in any joint is critical to get the function back, and that's been proven in the literature very often. And that's the case even with the distal radius. Now, that's why AAOS has come up with guidelines for when to fix them. So if there is radial shortening of more than 3 millimeters and dorsal tilt of more than 10 degrees, or if the article step of more than 2 millimeters, then you go for reduction and fixation. Now, what fixation method you use is variable to the fracture. To know what the displacement is, you need a very good radiograph, and it's very important to get a good radiograph of the wrist, like with any other part of the body. And if you look at the wrist, this has a 10-degree tilt polarly. So unless you lift your hand up to about 10 degrees off the table, you will not get a true AP or PA view of the wrist. And if you're taking a lateral view, you need to have this angulation so that you get a true lateral view of the radiocarpal joint. If you have any confusion of what's the alignment of the fragments or anything like that, go for a CT scan. Do not hesitate to go for a CT scan before planning for surgery. Now, there's good evidence now that volar locking plates and distal radius wiring have similar results, both in range of motion, in radiological appearance, and the function. So this was a conglomeration of about 8 randomized controlled trials, and that was the conclusion of the trial. So what is the key to success in any fracture treatment? You should know your implant, you should get the right fracture to fix it with the right implant, recognize the pattern, very, very important, and the right patient, obviously. Use the right technique. So know your patient, use the right technique. So looking at the implants I use the 1.6 wires usually for the K-wires for fixing the distal radius. Now we talk about K-wires, but there are various tips in the K-wires. If you notice the tip of it very carefully, you have a diamond tip and a trocar tip. The diamond tip goes into the bone very easily, but causes less thermal necrosis, but poor hold on the bone. So not so good to use for wiring. If you're having a trocar tip, has more thermal necrosis and better hold. But best hold is with the threaded guide wires, but taking them out is a problem in the clinic. So drill them slowly so that you don't get the thermal necrosis. You can also have a wet swab on the wire so that you prevent this thermal necrosis. So simple tip. Choose your patient right. So the fracture pattern should be right for the fixation. Now, I have been part of the draft trial, which was in UK for randomized control trial for distal radius. Surgeons were picking patients when they did randomized control trials also for this. So the results are a bit biased, I can say. There is a selection bias in it. Now, extra-articular distal radius fractures are the best for these sort of for wiring. And extra-articular fractures or even intra-articular fractures, which are minimally displaced but can be reduced, closed, these are the ones we should choose. And looking at the patient, a young patient with good quality bone is the best person for this particular procedure. Good cortical thickness is what you need for the wires to hold, and redisplacement can be avoided if the quality of the bone is good, but in osteoporotic bones, the redisplacement is very high. In fact, some studies have shown that the redisplacement is very high with these, and sometimes they come back to the original position. And a randomized control trial showed that even if you put a simple cast or a wire, you get the same outcome. So you're better off doing the cast. Now, looking at the types of wiring, there are various ones described. Intramedullary, you have the Kapanji type of technique, intramedullary wiring, or using the ulna to stabilize it, or our own Naidu's technique where you have the wire going up to the joint surface. But again, the problem there is the tip of the wire. Complications are nerve injuries, tendon injuries, pin side infections, and redisplacement. So to prevent these, we need to have a good technique. So have the safe zones of insertion. Avoid nerve injury by going blunt dissection down to bone, pierce the skin and then start drilling, and avoid tendon injuries by getting into the zones. These are the zone between 4 and 5 or 1 and 2. If you look at the bone quality itself, this is an osteoporotic bone. It's in a postmenopausal woman. If you see, this cortical bone is best. So you need to get your wires from there. So this is the wire configuration I would propose for the best hold of the bone. And technique-wise, pre-op antibiotic, tourniquet, II control, chlorhexidine 2% prep, preferably, arm board, and II control. In front of you, I sit at the end of the table, have a small towel and pull the arm, and then you have a free run around the wrist, and you can look at what you're doing. The towel helps in getting the correct PA view. So that's, you feel for the points of entry. Make sure that you are more distal to the actual bone when you're entering. So that's how you start. You should see where you are exiting. That's very important. So don't drill till you have the correct angle. And you're always starting volarly, so angle them dorsally. Single entry is the best one, because if you keep putting it in and out, you're not going to get the hold. So 2 wires on the radial styloid, 1 on the dorsal cortex, get in from the lip. And always get in from this corner rather than there, because if you look at the fracture pattern in distal radius, there is always a fracture line there. You don't want the wire to fall into the fracture line.